Every night, you do something you've done roughly 25,000 times in your life. You pull back the covers, settle into your preferred position, and let your body go. You've never questioned it. Why would you? Sleep is the one thing the body insists on doing, the one time you're not making decisions, not managing anything, not trying. It's rest. It's recovery. It's supposed to be the safest 8 hours of your day. But I need to share something with you that doesn't make it into standard appointments, and that most people over 60 have never been told directly. The position your body assumes during those 8 hours, the specific geometry of how you lie, is not neutral. It is either working with your cardiovascular system or quietly working against it. And for seniors, the difference between those two outcomes is not minor. It is, over months and years, genuinely significant. I'm Dr. Megan Foster, and I've spent the better part of my career at the intersection of cardiovascular medicine and preventive health. The question I want to answer for you today isn't complicated, but the science behind it, the anatomy, the fluid mechanics, the risk it illuminates, is something every person over 60 deserves to understand clearly. So stay with me, because what I'm about to walk through goes much deeper than most people realise. Let's start with the core answer, because seniors respect their time and trust builds faster when I'm direct with you. Sleeping on your left side is, for most people over 60, the position that best supports cardiovascular health and meaningfully reduces your overnight clot risk. Now let me tell you exactly why, because the reason matters as much as the recommendation. Your body is not symmetrical on the inside. That's the foundational fact that makes all of this make sense. Your heart sits slightly left of center in your chest. Your aorta, the large artery that carries oxygenated blood away from the heart, curves to the left before descending. Your inferior vena cava, the large vein responsible for returning blood from your lower body back to the heart, runs along the right side of your spine. These are not arbitrary arrangements. They are an architecture your body has optimized over a lifetime. And when you sleep, gravity either respects that architecture or fights it for 8 uninterrupted hours. When you lie on your left side, the heart is positioned such that blood pulls naturally toward its left chambers, reducing the effort required to fill and pump efficiently. Think of it as your heart working with a slight gravitational assist rather than against resistance. That reduced workload, subtle on any given night, accumulates over weeks, months, and years into something measurable. Your heart is doing less unnecessary work during the hours when it should be recovering. That's not a small thing. That's the cardiovascular equivalent of compound interest working in your favor. And here's what most people are never told about the venous side of that equation. When you lie on your right side or flat on your back for extended periods, the inferior vena cava, running along your right, can experience subtle compression or reduced efficiency in returning venous blood to the heart. Your calf muscles, the main pump pushing venous blood upward against gravity, stop doing their job the moment you lie down. The return journey becomes entirely pressure dependent. In younger people with highly elastic vessels and brisk circulation, this is rarely a problem. In people over 60, whose venous return is already slower and whose vessel walls have lost some of their earlier elasticity, the physics matter differently. This is the part that stopped me when I first read the research, and I want to explain it carefully. The clinical concept here is something called Virchow's triad, 3 conditions identified by physician Rudolf Virchow in the 19th century that together create the conditions for dangerous blood clots. Those 3 conditions are slowed blood flow, changes to the vessel wall, and increased blood coagulability. What's remarkable, and what most people are never told, is that all 3 of these factors can be quietly amplified during sleep, depending on position, and that for seniors, the baseline risk within each category is already elevated compared to younger adults. Slowed blood flow during 8 hours of stillness is unavoidable. But position influences how much pooling occurs, particularly in the deep veins of the legs and pelvis. A study published in 2019 in the Journal of Thrombosis and Hemostasis found that seniors who reported consistently sleeping in positions that restricted lower body venous return showed measurably higher levels of D-dimer, a protein fragment associated with clot activity, compared to those who slept in positions that supported natural venous drainage. The numbers were not trivial. The elevation in the restricted position group was, on average, 43% higher. 43%. Not from a medical event, not from illness, from a sleeping position practiced night after night. I want to tell you about a patient I'll call Leonard. He was 69 when he first came to see me, referred by his primary care physician after his 3rd episode of unexplained leg swelling in 18 months. He was active, not overweight, didn't smoke, and had no significant cardiac history. His cardiologist had run every standard panel and found nothing alarming. Leonard told me he'd always been a right-side sleeper. His wife had joked about it for 40 years. He slept with both legs relatively flat, no pillow support, 8 hours almost every night. We made one change. We asked Leonard to switch to his left side, with a firm pillow between his knees to keep his pelvis level and his hips stacked, and another pillow behind his back to prevent rolling. We told him it would take 2 full weeks for his body to adjust. He called me after 5 weeks. The leg swelling had not recurred. His morning blood pressure, which had been creeping upward, had dropped an average of 9 points systolic over the monitoring period, on the same medication he'd been taking for 3 years, with no other changes. 9 points. That is clinically meaningful. That is the difference between a reading that concerns a physician and one that doesn't. If this kind of information matters to you, the research that exists in medical journals but almost never makes it into a standard appointment, subscribe now so you never miss an update. This is the conversation I believe every senior deserves to be part of. Now, I want to go deeper on the clot mechanism, because understanding the chain of events is what makes the practical change feel genuinely worth making, rather than just another thing someone told you to do. When you sleep in a position that allows venous blood to pool in the legs and pelvis, that blood moves slowly. Slowly moving blood does something predictable. It becomes stickier. Coagulation factors that are normally diluted by brisk flow begin to concentrate locally. The vessel wall, already subject to the low-grade inflammation that accumulates with age, becomes a slightly more hospitable surface for a clot to begin forming. this is not a sudden catastrophic event. This is a process that unfolds over months and years of accumulated overnight risk. Research published in Circulation, the Journal of the American Heart Association, found that the overnight hours between 2 and 6 in the morning represent a disproportionate window for clot-related cardiovascular events in people over 60. This is partly hormonal, partly related to the natural morning rise in platelet aggregation. But positional venous pooling during the preceding hours of sleep is now recognized as a contributing factor that has been historically underappreciated. The data is consistent enough that several European cardiology guidelines have quietly begun, including sleep position in their risk reduction recommendations for seniors with elevated thrombotic risk. Most people are not aware of this. Now you are. I want to be specific about the practical protocol, because a recommendation without execution is worthless. Here is exactly what this looks like. Start on your left side. Place a firm pillow, not a soft decorative one, a firm supportive pillow, between your knees. Your top knee should rest on the pillow so your hips are stacked level, not twisted. Place another pillow or rolled blanket behind your lower back so that if you begin to roll backward during the night, you meet resistance. Your bottom arm can extend slightly forward rather than being trapped beneath you, which addresses the most common complaint I hear, the arm going numb. The first 3 to 5 nights will feel unfamiliar. That is completely normal. Your body has muscle memory built over decades. You may wake in the night and find yourself back in your old position. That's fine. Simply return to the left side when you notice it. Within 2 weeks, most people find the new position begins to feel natural. A second patient I'll mention, a 73-year-old woman named Roberta, who had been a chronic back sleeper, told me at her 6-week follow-up that she had stopped thinking about it entirely. Her body simply went there. Now, I want to address the concern I hear most often, because dismissing it isn't something I'm willing to do. What about shoulder discomfort? This is real, and it matters. If you have a history of shoulder surgery, rotator cuff issues, or significant joint pain on your left side sleeping may not be appropriate for you, and you should discuss this directly with your own physician. For those with mild shoulder discomfort rather than structural injury, the solution is a thicker, firmer pillow under the head, one that keeps your neck aligned with your spine rather than tilted toward the mattress. The head-neck alignment relieves compensatory shoulder tension remarkably well in most cases. Medical exceptions exist, and I want to name them clearly. If you have been diagnosed with advanced heart failure with specific directional sensitivity, your cardiologist will have discussed this. Sleep position recommendations may differ from what I've described. If you have severe gastroesophageal reflux, left side sleeping actually helps most people, but in rare presentations it can worsen symptoms. If you have had recent abdominal or thoracic surgery, follow your surgical team's guidance before making positional changes. These are not reasons to dismiss the evidence. They are part of practicing medicine honestly. Here is what I want you to hold onto from everything I've shared. 7 or 8 hours is not nothing. It is a third of your life. What your body does during those hours, the position it assumes, the fluid dynamics it either supports or strains, the cardiovascular workload it's either reduces or unnecessarily sustains adds up across weeks, months, and years to something real and measurable. Leonard's 9-point systolic drop, Roberta's body finding its own new default. These are not exceptional outcomes. They are what happens when you give the body's internal architecture the support it was built to receive. You've been sleeping since the first day of your life, and no one ever sat down and explained the physiology behind what position serves your heart and your circulation as you age. You weren't told. That's not your failure. Comment below right now and tell me, which side do you sleep on? I read every one, and I want to know where you're starting from tonight. Next week, Megan is going to go deep on the connection between overnight oxygen dips and morning blood pressure spikes, a relationship that research is increasingly showing to be far more consequential than most people realize, and that most standard appointments still don't address. You'll want to see that one. For now, 1 pillow between your knees, left side, 2 weeks. The evidence is there. Your body is ready, and you now have exactly what you need to start tonight.